Thank you, and good morning to everybody. Good morning, Luc. Good morning, Gorm. Good morning, particularly those of you who present here at the session of the Young Investigator Board of our society. It is a pleasure for me to speak about young and senior investigators and about relevant research, and I slightly rephrased my title to fit the contents I discussed with Gorm ahead of this preparation. I have one major conflict of interest to declare with my own sort of development and trying to become a senior investigator. And this conflict of interest I probably share with many of you. It is that every hour that I spend thinking, reading, preparing, writing for a research project, I do not spend with my family. And although I could be easily be replaced on the board and in doing clinical research, nobody would take on the responsibilities I have for my family. I'm a physician. I'm caring for very premature infants, and so I have to focus on physician scientists and on clinical research. And I apologize to all those of you who do basic research and who work in the lab. For my talk, I want to take into account that we have many more open research questions than resolved ones, and that apparently, at least I have to read this, less and less people are willing to engage into clinical research trying to optimize therapy. This is not something I experience at our unit, and perhaps we are very fortunate. I want to give you an overview about my talk. I want to start thinking about what is probably the most relevant clinical research, and I want to go on to develop the perspectives of junior and senior investigators and what type of research projects they should focus on. I believe there is a problem, and I want to show you where I think the problem is and how we can move forward. Why do physician scientists research? Lisa is just an example for the very sick patients we are all caring for every day. Lisa is an extremely preterm infant. She survived, but she suffered sequelae from complications following her very preterm birth. Her parents were not prepared for what they had to live through during her first months of life. It is for her parents, and for all our sick patients that we do clinical research trying to optimize our therapy. Beyond our wish to help, it is important to note that clinical research does not only has to sort of fulfill the idea of increasing our knowledge and understanding of disease, but clinical research, to be considered ethically justified, has always been to the benefit of the subjects enrolled. Either the personal benefit, for example, by offering them a new therapy that is not available outside clinical trials, or as a group benefit, sort of benefiting the whole group of patients with the same disease, and the latter only acceptable if the associated risk in this trial is very small. Consequently, clinical research always must offer the chance of changing patient management to the better, either by abolishing equipoise about the level of benefit of different established therapies, or by identifying and then modifying or eliminating harmful treatments or introducing new helpful therapies. There's no checklist that sort of makes you tick and then you know what is relevant research. In this absence of a sort of consensus, I made what clinicians often do if there's a lack of evidence. I started a small survey, and I asked the Council of the ESPR as an expert panel to identify studies, recent studies, that they would call most relevant for their patient care. Here's the list, and I'm sure you are aware of all of these studies. This list is only a start. It's by far not complete, doesn't matter. But it gave me the opportunity to show you the characteristics of studies that really change our patient care. And here are the characteristics. The median number of subjects enrolled in these trials was 1,316. The median number of study sites was 33, 11 authors in the median. If reported, the number of collaborators was 117. The majority of the trials reported long-term outcome. I have no clue what the mean duration from the first grant application to the final publication was, but I guess it was long. So in summary, clinical research that really matters, that changes our paradigms of treatment, includes hundreds of subjects and is necessarily collaborative research. It includes long-term follow-up, and therefore it goes on for years and years. Another observation of the small survey was that in this collaborative research projects, many more people contributed than actually had academic merit from their contribution. Having now almost spent 1/3 of my talk, I have to speed up a little bit, and I want to go on from the perspectives of younger to more senior researchers. And although these guys up there are males, the same applies essentially to female researchers, although I have to admit, and I don't have a problem with that, that our female colleagues usually are brighter, more eloquent, and more industrious than, for example, myself. So as we move on from a medical student to assistant professor to finally become a true senior investigator, we have to change our knowledge and to acquire skills. The perspective of a junior investigator are sort of given by this framework that we usually have a training position, so we need to rotate through different disciplines, which makes our available time in a certain discipline very short. Also, protected time, if available at all, is limited. Nevertheless, we are judged by the success we have. So, for example, by a publication as a first author within a given period of time. Apart from this research theme, we are certainly impressed by the clinical problems we encounter at the ward. And we still need to learn that the routines we apply in our groups don't necessarily are based on good evidence. Hopefully, we are all sort of supported by mentors, and if not, we should become mentees of more senior investigators. As a consequence, our research projects as junior investigators usually are more retrospective, observational, single-center studies with a limited number of patients or reviews of the literature. And considering what I said earlier about the most relevant research, these projects cannot make a lot of change to patient management. Please don't let me be misunderstood. This does not mean that these projects are not important. They are important for quality assurance and for generating hypotheses. They can set the ground for following larger trials. And first of all, they get us involved in the process of optimizing therapy. As we sort of go on, we need to cultivate our curiosity, our inquiring mind. We need to acquire, learn knowledge about research methods, and we need to learn to critically analyze data, our own data, but also that of others. Finally, we need to learn how to work in a team and to communicate. And finally, perhaps we get on to become more senior investigators, and I don't agree, I certainly have not made my way up there. I see myself somewhere in between, and I hope I have another 20 ASPR meetings ahead. And As a more senior investigator, the perspective should be different from that of a junior one. We have completed now the training, we have hopefully a permanent position, and we should be independent from immediate success. We should also be aware of the most pressing research questions, and we should become mentors of younger investigators. Our research projects now consequently ought to be prospective, interventional, multi-center, large-scale, perhaps randomized controlled trials, and hence should be likely to change patient management. We heard about some of these projects here on the Congress, and I really admire those who completed their large trials. But is that true for all of us all the time? Well, to challenge it, a very small and a very simple literature search in PubMed, searching for reports on newborn infants with the filters of human, infant, and the year 2012. You get 16,000 reports about studies done in this population. If you just add the filter randomized controlled trial, there are only 500 left. And of these 500 reports, less than 25% are primary reports for trials, and others sort of have this somewhere in the abstract. Less than 1% of these reports are on trials with more than 500 subjects. So I believe we do not have a problem with junior investigators at all, and this session is the complete proof for that. But we could do better as more senior investigators. So where is the potential problem? Is the senior investigator's true perspective actually different from what I showed before? Is there perhaps too much competition to prevent us from doing collaborative research? Too little training in performing large prospective trials? Or too little or too expensive infrastructure? Well, yes, I think, unfortunately, we are not completely free of the need for short-term success, even as more senior investigators. Because when we apply for positions or grant applications, at least I have the impression that, well, please list all your publications and please give a summary of the sum of impact points you have acquired. Okay, thank you. This is probably not helpful. At the same time, we compete for the same funding for our institutions or for ourselves as scientists. And we compete for the same positions. And competition is good because it sort of makes us try to do better. But at the same time, I believe that too much competition hinders us to promote collaborative trials. Because, you know, I have to get my own project going. I can't help you with your project. There's also a little problem with training, I believe, because if we embark everybody on small retrospective observational studies, how do we learn to conduct large collaborative trials? Beyond that, we need to even more work in a team and even more to communicate. We need to learn to share academic merits of our work. And we need to learn, first of all, perhaps to hold on and not to give up. Gene Dempsey yesterday presented what challenges he encountered going on with his dopamine trial. And this is what I mean with sort of holding on, not giving up. Do we teach that enough? And do we provide enough mentoring? Sort of, do we hold, as people who had done giant research, the hands of those who embark into large collaborative trials to help them and prevent them from going into the same pitfalls those of you who sort of successfully managed to get on these trials had encountered? And yes, there's too little infrastructure for low-budget trials. It is not easy to have access to a database with remote data entry At least we had the experience in the past. It is not self-evident that there should be a study nurse available in every tertiary care center. And there are still probably too few networks of people interested in interventional studies. We have now a wealth, and I really acknowledge that, of epidemiological networks, and those are important for benchmarking. But I believe that the networks of people who do interventional research are slightly different and perhaps should be supported more. What do we in Tübingen try to do? Well, first of all, we contribute to our national neonatal network. We also contribute our data to the Euro-Neonet. Beyond that, under the leadership of my colleague and friend Dirk Basler, we invented the Center for Pediatric Clinical Studies, a university-based pediatric study center which could act as a contract research organization with a quality management system that is certified and therefore suitable even for studies that would go on for drug authorization. Our aim is really to increase availability of adequately studied therapies for children. And we have already some experience in the conduct of large European multi-center trials in neonatology. Dirk Basler is the principal investigator of the European study of inhaled steroids, one of the first FP7 projects funded in neonatology. And myself, I'm happy to have a group of people together working on the ETNO trial, the trial of transfusion thresholds, and their effects on neurocognitive outcome. Our center provides infrastructure, a database for remote data entry suitable for any group that would be willing to engage into a large collaborative trial. We can give data management, central monitoring, and help with pharmacovigilance. We are aiming to increase training, GCP training, as well as rotations of young investigators through our center. And we can give regulatory and biometry support. This is still a local thing. Some 50 years ago, Honorable Martin Luther King held his I Have a Dream speech. And where, if not here in the session of the Young Investigator Award of our society, can we envision a dream of more European collaborative clinical trials? So I would like to encourage you to form networks of collaborative centers, as well as junior and senior investigators seeking high-quality research rather than high personal academic output in the best interest of our patients, and sharing what we have as academic merits by group authorships or by sharing sub-project publications. And I hope for an academic environment that is no longer counting the number of publications or impact points. This is not the most important thing. Oops. Okay, let's go back. Sorry. I hope for more training preparing for the conduct of collaborative trials. And perhaps this is an idea for the next research summer school of our society. We should learn from the big shots and from those who successfully conducted the very large trials. We should, as more senior investigators, give a good example to our junior investigators and contribute ourselves to larger projects. And we should try to get those younger people involved. At the same time, I ask you, why do we have actually psychologists on every tertiary care ward supporting the parents? Well, there are good reasons for that. But at the same time, it is still a paucity of research nurses. At least we experience that in the ETNO trial. And we have troubles in those centers who do not have support from research nurses. But perhaps having a research nurse, at least part-time on every ward, that would also increase our knowledge about good patient care and help eventually the babies. Harmonization of long-term follow-up has been suggested by Adolfo Valsi-Soler for his Euro-Neo network. This would certainly help as well large prospective trials if we had a standard of follow-up throughout Europe. So in the end, I hope we have many of these kind of very great beautiful multi-center trials, but oops, we could do a lot better than that. I feel it is important that those who contribute actually get the merit. Thank you very much.